Okay. Okay. Okay, guys. I'm going to talk today. I want to review. So, if I go too fast or anything on the review, well, you still have an original video to look at. Um, so, you can ask. Don't. It doesn't mean don't ask me questions. I love questions. I wish I had more, quite frankly. But today I want to review the renal artery exam. Uh, Arguably the most difficult. One of the more difficult exams we will ever do because most people are rather difficult to scan, at least the renal artery itself. Now remember, there's two parts of this exam, and everyone always, we do it backwards as far as I'm concerned. We start with the direct exam, and then we go to the indirect exam. In my opinion, the indirect exam is more, it's easier to do, and it actually tells us whether or not there is something wrong with the direct exam. So, but we'll talk all about that. We'll talk a little bit about renal aortic ratios. Not a big deal. It's literally, if your computer for some crazy reason doesn't figure it out automatically for you, it's just simply a simple division, renal aortic ratio. So peak velocity over peak velocity, easy stuff like that. Resistive index, a normal resistive index of the kidney as well, and then just some techniques. So without further ado, I started a little picture here that we can go. Where is it? There it is. We can go to. All right. Let's mark pages because I don't memorize everything, believe it or not. Okay. So remember I said there's a two-part exam. We have obviously we have a aorta. I just quickly drew in the mesenteric arteries, the celiac with its branches, and the SMA. I didn't draw in any veins on this because it's an arterial exam. Quick note though, and I know I've said this before, but just as a reminder, it's not a Doppler exam. In other words, not a billable Doppler exam unless you do a renal, an artery and a vein. So on this exam, and I'm saying this now in case I forget, it's artery, 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 artery. All you need is one good sampling of a renal vein going in, leaving the kidney, and that's it. And then now you officially have a Doppler study. You definitely always want to make sure that you get the vein, not only color Doppler, but spectral Doppler. Once you do that, it is officially a Doppler exam, and you can legally bill for it. If you don't do that, it's actually not a correct exam. All right, let's see. Let's talk about the initial exam, the first part, and that is the direct exam. Really quite simply, we just need a peak systolic velocity of the aorta at level of renal arteries. So, and that's our first sampling. That's our first spectral peak systolic velocity. So obviously we're doing a spectral, angle corrected, because we're getting a velocity. For this part of the exam, angle correction is very important because when we're comparing velocities, we have to have an angle correction. Peak systolic velocity at level of renal arteries, and then at a minimum, the renal artery, prox, mid, and distal. Proximal, mid, and distal. Once again, we need those peak systolic velocities. And what we do is we simply plug that all into the machine. Hopefully your machine will do it for you, but if not, like I said, it's very easy. It is the renal aortic ratio. as in the renal artery peak systolic velocity. That's not a minus sign, that's just simply that's not a times sign, that's just simply there. In fact, I'm going to erase that. Don't want to confuse. All right, renal artery peak systolic velocity divided by the aortic peak systolic velocity. So we'll do this for proximal, figure out what that is. We'll do it for mid, figure out what that is. And distal, figure out what that is. Notice this didn't change down here because there's only one. Let's say it's let's just say it's 75 centimeters per second. That's gonna remain 75 centimeters per second for each of the renal artery imaging. Of course, this is right and left. We'll just talk about, let's say, the right side today. Now, let's just erase some of this stuff. So let me show you what that theoretically looks like. Obviously, ultrasound, doing the exam is always a lot harder. So theoretically, that means you put your spectral, let's say right about there. You put a spectral there, angle correct. It's kind of hard to angle correct on a 2D image like this, and so I'm not going to. I mean, we'll call that, you know, like angle correct, and this one's like angle corrected to 0 degrees. Proximal is here. So we have another angle corrected. And ideally, guys, you see the entire artery, because we could sample here and then sample here for mid, and then sample here for distal. However, having said that, just like everything else in ultrasound, if the stenosis is here, then that's the important part. That's the part you find in this area here. That is the part where you find the highest velocity. And if it's closest to distal, then we call it distal. You know, if it's closer to mid, we call it mid or whatever. But chances are, most of the time, plaque builds at the beginning of arteries. So chances are pretty good that you'll find it here at the proximal aorta. Now, remember, guys, we're going transverse on the aorta. You see the SMA. Let's just say that I have my transducer right there, transverse at the level of the renal arteries. Now, what does that look like? Oh, let me draw this out really quickly. I'll cheat with a circle here. And I'll cheat with another circle. And you might see a little bit of IVC and let's just do that again. Actually, let me move my circle over. Actually, let me take my entire image, canvas size, keep that, and let's go with 2100 pixels. Okay, that's just a little more room for me. Okay, let's do this over again. Sorry about this. Here's my aorta. What's the smallest circle, guys? Above the aorta. Usually has an echogenic surrounding. Is the SMA. I can draw in just a quick, just for reference. And IVC. So we have IVC, aorta. We have a little bit of the left renal vein. Of course, that comes in, from that direction. We don't always see all of it, especially when we're at the level of the renal arteries, because the renal arteries and the renal veins are slightly different levels, like within a centimeter, probably half a centimeter of each other, but still, you usually don't see them perfectly at the same place. Okay, erasing a couple of spots here for, of course, my renal arteries. So for some reason, this guy tends to go up and then down. And usually it's kind of hard to follow beyond here, so I'm just going to draw it that far. Now, if you're lucky, you'll see that much of the renal artery. And then on this side, it tends to go more or less straight down. And you're lucky to see that much as well. There's usually a lot of shadowing over on this side from stomach or colon. I don't need to draw in color. Just obviously, this is red, this is blue, just by standard colorization. So this is what it looks like to get a proximal. Let's make sure we understand. We've had some problems. That's proximal aorta. Distal aorta. Right. Left. Let's just, if you don't mind, I'm just going to go and do a few more. Proximal. We could also say, good Lord. We could say good Lord, but we could also say superior. We could say cephalic. When you say superior, you're always referring to something that's closer to the head as, superior is closer to the head, and cephalic is the same thing, but I tend to use the word cephalic when I'm talking about I'm moving in a direction. So move cephalic. So cephalic just means head, so that's same thing. And so distal. Now distal refers to, let's say, a blood vessel. Your blood vessels in your upper leg are proximal. Your blood vessels in your lower leg are more distal. Same thing of the arms. By convention, we speak of arteries and veins in the same way. So proximal vein would be in your upper leg. Distal vein would be in your lower leg. The distal IVC would be down here. The proximal IVC would be up there. Technically speaking, that's incorrect because blood travels in opposite directions, but we're not going to worry about that. Just know that technically speaking, that is incorrect. Okay, let's see. We can call this also inferior and caudal. Inferior just is, anything towards the feet is inferior, and caudal is your back end. And so that generally refers to your or the patient's actually butt, the rear end. So you actually don't use the word caudal when you're like in the leg or in the arm. It's kind of awkward to say move caudally. And it's like, well, wait a minute. Caudal refers to the posterior end, but so it's not always perfect. Okay. So I'm going to draw a circle in here. Kind of a funny circle. Let's see. What I just circled is the extent of the direct exam. The direct exam, the extent of which goes from the aorta to the distal Actually, let's go ahead and write that down too. When it comes to arteries going out like this, proximal is always closer to the heart. Okay, so your direct exam goes from the aorta to the distal renal artery. And what's important in this exam is velocities. So we always angle correct in the direct exam. I started drawing over here. This is what the proximal renal arteries look like. This is probably the best place for you to get the proximal renal arteries is transverse on the abdomen. Then you just get your spectral gate right there and there. Sometimes you just can't get it here. It's too gassed out. Then we're going to look sideways to the body and try to get all the way back to the aorta. Very difficult to do, especially for the right kidney. The right renal artery is 2, maybe 3 times as long as the left. Why? Because the aorta is on the left side. In fact, in reality, if I were to draw the kidney on the left, it would be almost on top of, or like within an inch, within a half an inch of the aorta, very close to the aorta. We tend to draw things out with a little more expanded view just so we can draw them. Okay. So then we look at the kidney for the second part of the exam, which, as I've stated before, I think should be the first part of the exam. And that is the indirect exam. So let's write that down here. Indirect exam. This looks at basically the waveform. We don't care. Look, if you're up in the parenchyma of the kidney, you don't have to bother. You can. It's not going to hurt you. Not going to hurt the exam, but you really don't have to bother with angle correcting up here because we do not care about the velocity. If you're going to do it right here on the, oh gosh, of course I grabbed the wrong image for my segmental. The segmental arteries, go ahead, angle correct. Once again though, unless you're using your segmental arteries in your direct exam, which you probably shouldn't be, the angle correct is not important because velocity not recorded. Velocity not recorded, so we don't care. Remember the waveform, if it looks, let's say, like that, we got the kind of early, remember what this is, guys? Early systolic peak. So you may or may not have that on your image. There's the baseline. Oof, okay, you know what I mean. But in any case, whether I have angle correct on or not will not change the look of this waveform 1 iota. The only thing it will change are the velocities. So if you want to know your peak systolic velocity, you have to angle correct. If you don't care, you don't have to angle correct. Okay, so let's see if I can remember these. You have first tier and second tier, but we're just gonna, don't worry about that. We're just gonna call these, what did I just call them? Segmental. So normally when we do, well, let's just finish this. Segmental arteries are basically in the collecting system here. They can start outside of the kidney for that matter, but they're still, they're obviously what they are. They are what they are. Let's just put it that way. And then we have going into the parenchyma on either side of the pyramid are the interlobar arteries. Crossing over the top are the arcuate, arcuate arteries. These are the ones that cross over like this. They arc over, I should say, because they're arcuate arteries. And what do we call these guys? There's actually two names, interlobular, but that gets very confusing because you have interlobar down here. So I think most people, including myself, are preferring the let's see, radial cortical. I gotta put on cortical radiate. Let me pause. Yeah. Just ask Siri. Not radial, cortical radiate. Cortical radiate arteries that's a better term for these arteries because they are in the cortex and they radiate out. I mean, how do you not remember that, Kurt? I don't know. Okay, so with this part of the exam, well, we're going to throw our color on, and we're going to see color. We're going to see arteries, and we're going to put our whoops. We're going to put our non-angle corrected pulse wave region of interest, or a little spectral box here. We're going to put one there. We're going to do a we usually call it upper pole. Mid pole, which is a bit of a misnomer. How you have a pole in the middle, and then lower pole. And so that's the vernacular, that's the wording that most people use. Upper, mid, and lower pole. You could say superior, mid, and inferior poles as well. That's same difference. And I am recording, right? Yes. So if I did one right here, and then maybe I'll do one right here. Oops, and then one right here. Wherever I see the color is going to help me decide where exactly these go. All right, obviously. And generally, if you hit those three areas, you're pretty well set. Now, some people, and they're going to say, "Oh, you're getting arcuate." You know, the computer's going to say arcuate artery, or if they're even crazier, they'll say cortical radiate artery. Baloney. If they have a really a small child and a really good equipment, then yeah, maybe you could scan those. But realistically, I think most people are getting the interlobar arteries. It doesn't really matter. All that matters, because whatever problem exists, let's say here in this arcuate artery, is also most likely going to exist here, and is actually going to exist down to here, and probably all the way down to here as well. So wherever you get a good signal in the upper, mid, and lower poles, they might require you to do segmental arteries as well. Fine, just add those to the bunch. That's an upper, mid, and wherever I'm finding a good signal, lower. So now I have 1, 2, 3, 4, 5, 6. It actually gets a bit redundant, but okay, you do what you do. So imaging these are what we're looking for here. Now what we're looking for is not a renal aortic ratio. That was already done with the direct exam. With the indirect exam, we've got the waveforms. And so let's think about what a waveform might look like. A normal waveform will be sharp, actually even sharper than that. You're supposed to have an ESP, early systolic peak, but I'm not a big fan of saying you have to have that, because Lord knows these exams are hard enough, and you have to, in order to get these early systolic peak, you have to be very well, your Doppler angle has to be very, very beneficial, like close to 0. And that's not always possible. So ESP is great. If you do see it, then I pretty much guarantee you don't have tardive parvis. Okay, so, whoop, no, it just has a nipple on it apparently, but could have drawn it a little. Let's get rid of that one. Let's get rid of it entirely. Okay, ooh, that's super sharp. And there's my tiny little peak there. That's more like what it's supposed to look like, right? Okay. All right, so you know, you get the idea. Early systolic peak is great. If you don't see it, I'm not freaking out. But low resistance, in other words, the difference between peak systole and end diastole is not that great. In other words, plenty of forward flow. Sharp rise, in other words, a small acceleration time, AT, acceleration time. Remember, that's the time from end diastole to peak systole. The time frame from here to here, between these two dots, there, and there, is your acceleration time. That should be very small. Issues, of course, we all know. This one still has low resistance, but not a sharp rise. End diastole, peak systole, now the acceleration time is much longer. Acceleration time really tells us what? It tells us whether or not there is tardive parvis. This is an indication, this is an image of tardive parvis. Now, tardive parvis occurs when? After a stenosis. All right, so if there's a stenosis, so, and this is why I really prefer, if you think about it, guys, if we go straight to the indirect exam, we find waveforms all over the kidney, not just in one place, because you can have half a kidney or even a third of a kidney with tardive parvis and the rest of it's normal. But if you go up and down that kidney and all you find is sharp rise, small acceleration times, no indication of tardive parvis, then we know the first part of the exam is normal. So why we do this backwards is beyond me, but I don't know, maybe there's a reason that I'm not aware of, or maybe it's just a bad habit. So what was I just going to say? After stenosis, oh, right. So why are we doing this exam? Well, here's the thing. For most of my career, I'd look at the kidneys, I'd measure them, I'd look for masses, hydronephrosis, stones. That's what you're doing, by the way, when you're scanning back and forth through a kidney, is looking for anything unusual. And then I would throw Doppler on the kidney, and I would say, oh, look, it filled up beautifully. It must be normal. No. And so I actually stopped um, doing that once I realized that I was just kind of I wasn't really adding much to the exam. It might be pretty, and maybe your doctor wants a color picture. That's fine. But what it's not showing is whether that color is associated with this or this. Because you could have plenty of blood flow in a kidney, but if it's all tardus parvis, well, what happens after stenosis? Post stenotic blood pressure, it never comes back, guys. Remember, you go through stenosis, increased velocities. In order to increase velocities, we have to steal energy. That energy is stolen from pressure. Now, you might, after, of course, there's also post-stenotic turbulence and all that stuff, but really it's the blood pressure that goes down. So what happens? Now, the kidney might be seeing, it may have plenty of flow, or just, blood in general. There's plenty of blood going to the kidney, but if it's low blood pressure, then kidney will react. Now, here's the thing about low blood. If it's very low blood pressure, the kidney might actually even die. Even if it gets the volume of blood through. If it's very, very low pressure, then there's not enough exchange of gases to keep that kidney alive. But more likely, what's going to happen is that the kidney will react. And what is that? That's the renin angiotensinogen cycle loop feedback. Or feedback. The renin angiotensinogen cycle feedback. That's another term I'm thinking of. That's okay. Look, we don't really need to know a lot about this. All we need to know is that when the kidney sees low blood pressure, it thinks, oh, the whole body has low blood pressure. It's my job as a kidney, as someone who's obviously going to be changing blood pressure because I change blood volume through urine, production of urine or lack of production of urine. I see low blood pressure. I'm going to release renin. Renin is going to find angiotensinogen. It's going to change it from angiotensinogen 1 to angiotensinogen 2, but that doesn't matter. And what that does is angiotensinogen is going to tell the entire body to raise the blood pressure. And so your entire body has, and so you, as the individual with a stenosis in the renal artery, you now have high blood pressure. Well, okay, so your doctor gives you some drugs for high blood pressure, and guess what? It does not change. Because no matter how much your blood pressure increases, your kidney will continue to see low blood pressure because it is continuing to be post-stenotic, the post-stenotic situation, always creating low blood pressure, which means the kidney is always going to continue to create renin and angiotensin. And so it's a loop that keeps on going. And a lot of your patients, they'll be coming to you, one, because they're just not a candidate for high blood pressure, doesn't make any sense. Or what I usually see, uncontrolled hypertension. That's your RX, your prescription is uncontrolled hypertension. Renal artery Doppler or renal artery duplex. So your prescription, renal artery Doppler, renal artery duplex, why? Uncontrolled hypertension. And also remember, guys, that kidney is very powerful. Very powerful. It can be one kidney causing this. It could be 1/3 of one kidney. So let's say there is actually a stenosis right here. Well, I just kind of drew an occlusion, didn't I? But I mean, this is a stenosis here. And if there's a stenosis there, that means this part of the kidney sees low blood pressure. That makes sense. This is a upper pole low blood pressure. That does not make any sense. Like that. Low blood pressure in the upper pole. It releases renin that goes to the blood, finds the angiotensinogen that creates high blood pressure in the entire body. High blood pressure. Your kidney down here is seeing, well, your entire kidney is now seeing, no, I'm sorry, your kidney down here is seeing high blood pressure, but the kidney up here continues to see low blood pressure because the blood, no matter how high it is here, no matter how high the pressure is here, it always ends out to be low blood pressure after going through the stenosis. And so this part of the kidney, this 1/3 of this kidney, continues to see low blood pressure. It continues to cause the renin-angiotensinogen loop to occur, which continues to cause high blood pressure, which is why we see a script, renal artery Doppler, renal artery duplex. Why? Uncontrolled hypertension. I'm going to pause just for a second. I want to get one thing for you guys. Okay, guys, I just want to get my numbers straight. I knew it was low, the RI. So, but I wanted to get you something somewhat correct. So, resistive index. So, first part of the exam, the direct exam, we're getting the RAR, renal aortic ratio, and that is simply a division. RAR, that's for the direct exam. For the indirect exam, which we're describing over here, we get the RI. That is resistive index. The RI, get a little closer in here. Now, okay, let me write it out and then explain something, because this is going to be a little confusing. Peak systolic velocity minus end diastolic velocity divided by peak systolic, peak systolic velocity. Now, if you've been listening, you'll be like, wait a minute, you just told me that the velocity is not recorded, and we're only looking at the waveform. Well, that's still true, because So I said the RI, resistive index, is going to look at peak systolic velocity minus end diastolic velocity divided by peak systolic velocity again. It does not matter what the scale over here says for your resistive index. If the top of the scale is 100 and we have, let's see, 80 minus, let's see, 80 minus 40 divided by 80, or if this is much faster and the scale actually reads 200, and this is now 180 and 140, we're still going to get the same result. So even though I told you angle correct does not matter because we're not really recording velocities, we could still use the velocities whether they are accurate or not, because if they're inaccurate, they're universally inaccurate. The peak systolic velocity might be off by 20%, but then again, so is the end diastolic velocity. That will be off in the same way, you know, too much, too little by 20%. And so you'll end out getting the same index. So a normal renal is 0.5 to 0.7, and that is a normal renal RI, okay? So in essence, and I should have mentioned RI earlier and I didn't, but that's fine. I think we'll all figure this out. In the indirect exam, we're looking at the waveform. We're looking at the acceleration time, which is the same difference because the acceleration time is telling us, it's just basically that acceleration time is giving a numerical value to tardus parvus. A very small acceleration time, no tardus parvus. An extended acceleration time, tardus parvus. But quite frankly, we don't even need this number. As sonographers, we take one look at these two waveforms and we know that this is normal and that's abnormal. At least you will after doing 100 of these. So that's one part. I guess I should have said this, that the resistive index is also looked at. The thing is, though, yeah, actually with tardus parvus, your resistive index will actually go down, which is a little, wait a minute, this is, why is it going down? Well, it's actually because peak systole is muted. And when that's muted, it actually can get close. And if you continues to have low resistance flow, if you continue to have low resistance flow, your RI will go down. So RI will be unusually small for tardus parvus. So that's another way of looking at whether or not it's tardus parvus. The RI is too small. And by the way, RI is high. That tends to be more like rejection. So if it's a kidney transplant, the resistive index is high, meaning you have less resistance. I'm sorry, you have more resistance to flow. You have more resistance to flow, the resistive index is going to increase. But we're not going to find that in this exam because that'd be unheard of. I mean, not unheard of, but that's just not what we're looking for. So the resistive index is definitely part of the exam. It kind of tells us what we already know, but doctors like numbers because numbers are more repeatable and they very easily go into the reports and everything. So a normal is 0.5, 0.7. If it actually goes to 0.4, well, that's because the difference in peak systole and end diastole is too small. That makes sense? I hope it does. Okay, that's it. I'll just say, and let's go back to my beautiful face here. I just hit stop share. Yes, apparently. Oh. You know what? I did have some. I knew it. Well, let me go back to share. I did forget something. Damn it. Share screen. Okay. I gave you a normal RI. I didn't give you the RARs. I totally forgot about that. I was going to quickly grab it. I had it right here. Normal resistive index. Remember, this is done 3 times. Prox, mid, distal. Well, you only do more if there's a reason to do more, like you found a stenosis and you want to do a couple more just to figure it out. Less than 3.5 is normal. I'm not going to give you peak systolic velocities. I don't like those numbers. But, all right. Now, here's the thing. I'll tell you. Okay, so that was, I think that's the only thing I forgot. There's acceleration times. What? I've given those before. Oh, what am I doing? Stop share. Okay. So on that renal aortic ratio, I'll just tell you a story. I think I've already told you this, but you're a captive audience, right? Actually, no, you're not. You could just hit. You can just stop the. So as you guys know, I had this one doctor. It was a nemesis of mine. He made a lot of mistakes. Smart guy, but he was just in every direction. I had a patient with a normal renal resist RAR, but an abnormal, so a normal direct exam, but an abnormal indirect exam. And clearly tardus parvis in the kidney. I can't remember if it was the whole kidney or part of the kidney, but clearly had tardus parvis. Resistive index the number was off, the acceleration time was off. And, but all he knew how to do was to look at the RAR. That was the only number he ever memorized. And so he had a normal RAR, renal aortic ratio, but clearly tardus parvis, and so he calls it normal. And I was flabbergasted. I was infuriated because, you know, since practically an hour of my time doing this exam, it's a really hard exam. Why was the renal aortic ratio normal? Because I never found the actual stenosis. I didn't bowel gas or whatever. It was just the actual stenosis was hidden. So every time I can compare the renal, the aortic to the renal, or renal to the aortic, I should say, whenever I can make those comparisons, every time they were normal. So that's why it's so important to do that indirect exam, and that's why, quite frankly, I think the indirect exam is better than the direct exam. Now, if you actually find the stenosis, that's the best thing to do. but it's so oftentimes you miss the stenosis because it's buried in there. So I was infuriated, but what are you going to do? What's the patient going to do? So what's your moral obligation at that point? Because the ordering doctor wants to know what's going on. You know what's going on. The patient wants to know what's going on. It could save knowing what's going on could save their life or give them a better life. But your radiologist has overruled you. So don't do what I would do, which would be like, pick up the phone and call the ordering doctor. Don't do that. Don't ever do that. If you feel very strongly about it and you have a doctor who will talk to you, then go talk to your doctor and say, look, this is what I'm seeing. And then if they're reasonable, if they're a good doctor will actually listen to you. And then they might be like, no, Kurt, you're still wrong. I'm sorry. I know this a lot better than you do. At that point, okay. If you have a jerky doctor, you could go to another radiologist and say, look, with all due respect, this is what I saw. Now, they could throw you under the bus. So you got to be careful about that. They could throw you under the bus and say, hey, Kurt's complaining to me about you. Okay, you're screwed at that point. So what do you do? Of course, you could always go to your supervisor too. They could be able to help you a little bit better. But even there are other radiologists, and I've done this before, even there are other radiologists like, oh, Kurt, what am I supposed to do, with this? How do I approach this doctor? So it could be difficult. It's a moral quandary. Lose your job, save a life. It's difficult. And I have risked my job a couple of times. Amazingly, got away with it. Anyway, I don't know why I decided to go on that little tangent. I guess just a little bit of fatherly advice. Okay, I am done. Yes, I am done.